I'm Dr. T.S. Sridhar. I'm currently at the St. John's Research Institute, which is part of the St. John's Medical College located in Bangalore. And I've been there for the last 10 years. I'm both a medical doctor by training as well as having a background in research by getting my PhD. So I'm what is called as a scientist doctor or a doctor scientist. My interest in breast cancer has been over the last 10 years, and it arose from a common refrain I heard when I returned to India from having finished my training in the US, which was to say that breast cancer in Indian women is different from breast cancer in Caucasian Western women. And while at the face of it this seemed to be true, we wanted to try and understand this at three different levels. So we wanted to try and understand what the differences were due to the cultural differences between India and the West. And next, the demographic differences. India is a very young country versus the Western populations. And the third, and most importantly from the point of view of treatment, whether there were real biological differences between the breast cancer in Indian women versus Western women. So that's what got us started about now 10 years ago. And the way we went about doing this was actually in a very different way from what a research group would do in a basic research institute or in a clinical center. We started off by establishing a breast cancer support group called the Adhara, which was manned by young trained medical counselors who were able to first meet with the patient and their family and establish a rapport with them and get to know the socio-economic background in which these women were embedded, and then get to know their actual challenges in going through the treatment. We then worked very closely with the pathologists and then the medical doctors, and most importantly we stayed in touch with these patients. Now the longest of our patients we have stayed in touch with for more than 8 years. So, and our approach was a combination of the socio-cultural, the demographic, as well as the biological differences in breast cancer in Indian women compared to what we already knew about breast cancer in Western women. It's very interesting. What was known was breast cancer in India happens on average about 10 years earlier than breast cancer in Western women. It's about 60 years, the median, that is, half of all women with breast cancer in the West have it after the age of 60, and in India it is a decade earlier, which is 50. Half of all women with breast cancer in India are under the age of 50. So that was known before we started our work. So we have actually confirmed that finding, that in India it actually is happening earlier. But if you look at the demographic of US, the nation where I worked and for which I know the statistics, the median age of women in the US is a little after 35, right? And if you look at the median age of Indian women, it is now about 28 years. So the population itself is left shifted, meaning we are a younger population. We have far more younger women compared to the West. And so the demographic is part of it. Now, what we found most interesting was on the socio-economic angle. We naively believed that if a woman was more educated, she was likely to seek care early, and actually so educated women would come to the doctor earlier than people with no education and from lower socioeconomic strata. Surprisingly, that was not what we found. we made a very simple assumption. We took women who had a college degree and people who had no college degrees. So that was very clear. People who had stopped their education after school and people who had gotten through college. And then we asked a very simple question: are there more late stage tumors, meaning women who came to the doctor late, in the uneducated versus the educated? And we found actually there was no difference. So what many people have alluded to, the socio-cultural norms in India that does not allow a woman to speak about a lump in her breast, have actually persisted despite being exposed to higher education. So it's truly a cultural problem. And the way to deal with this, obviously as a consequence, is to attack it at its roots. And so that is number one. On the other hand, we found something very reassuring on the biological side, because breast cancer broadly is of two types. The type that expresses the receptor for the female hormone called estrogen receptor. So if it expresses that receptor, it's called estrogen receptor positive, and if it does not express that receptor, it's called estrogen receptor negative, right? And younger women have estrogen receptor negative breast cancers. So half of all Indian women have estrogen receptor negative breast cancer. And the difficult part of that, or the sad part of that, is these tumors are more aggressive and you can't use the anti-hormonal therapy that is used in the postmenopausal women in these women as effectively, and so they tend to do poorly, ER negative tumors. What we found was that while there were more ER negative tumors, whether a tumor was ER positive or ER negative, once its biology was established, its behavior was independent of ethnicity. So an ER positive tumor in Western women, a ER positive tumor in an Asian woman, a Japanese woman, or an ER positive tumor in an Indian woman behaves the same way, right? A ER negative tumor in an American woman or an Indian woman behaves the same way. So though many people have a confusion, so because we have more ER negative tumors, they think Indian breast cancer is more aggressive. No, that is not correct. Breast cancer aggression is related to its biology. If it is ER negative, it is more aggressive. If it is ER positive, it's more manageable. So that was a very important thing that we established. It is not that this was not known to the doctors. The doctors knew it all along, right? All of the treating physicians have always known this. But the lay public and the myth that breast cancer is more aggressive in Indian women was pervasive. The third thing which we found, which is probably the most gratifying, because most of our patients were treated with the standard surgery, radiation and chemotherapy. In the general ward, all of this adds up to about 2 to 2.5 lakhs of rupees in Bangalore today, right, in a private setup. The outcome of all treated patients, if they came to the doctor early, meaning before stage 2, stage 1 and stage 2, they are now doing just as well as people treated anywhere in the world. So the mythology that unless you have all of the most modern therapies and that we can never equal the outcomes of the West is just not true. Again, this was very well known to practicing doctors. They have always known it. But what we have done is we have actually followed these women over the last 8 years without any loss and established this at a statistical level. You're asking me a very difficult question, because the sort of research that we embarked upon was not with the goal of being able to help doctors improve or change their treatment immediately. In fact, I'll take a slight digression based on this question, and I'll tell you that research that has to have a significant impact on the outcome of a disease as complex and complicated as cancer takes a very long time. The gestation period of the research is many, many years, if not decades, before its impact on treatment is obvious. So, if I were to answer your question very bluntly, our research has not directly impacted patient care in the short run. However, what we have done, because we did the molecular genetic analysis of these tumors, is we have developed certain tests which now permit us to put these women into categories, ER positive, ER negative, subcategorize them, people who might respond to one therapy better than the other, people who might have a propensity for the disease to spread, and these tests are actually in development, and it's likely that they will be available for patient care. But in the short run, our research has not actually helped the patients directly. But it is unless you do research of this kind that the next generation and the next group of people who follow up can build on this to develop the patient impacting diagnostics or therapies that are likely to come.